go through the script. I can start?
Yep.
Thank you so much. Good afternoon, everyone. Welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearings. Staff will not allow anyone who was not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witness timing. The bill sponsors or a designee is allowed 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask you questions. Next, 5 witnesses will be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear the timer ring. Please, we appreciate it if you adhere to that. Members must remain present with your video camera on during the entirety of the hearing. These are the rules. Members, please ask only one question of one witness. If you have other questions, you may follow up on it. Please use the raise hand function to indicate that you have a question. And if you do have a question, please use the icon. In 1 second, please. Okay, and I'm going to tell you the order of the bills. 1 second. Is the following: House Bill 549, House Bill 442, House Bill 605, House Bill 462, House Bill 710, House Bill 547, House Bill 548, and then we have House Bill 552, which is actually jointly assigned with appropriations. And then the last bill of the day will be House Bill 598. Melissa Bender is excellent at letting us know in the chat room what our next bill is. So we appreciate that to keep us orderly. So the first bill that we will start with is House Bill 549, which is myself, Delegate Pena Melnick, and the title is Maryland Department of Health, Birth Registration Gestational Carriers. So good afternoon, Chairman Pendergrass and members of the committee. Thank you for allowing me to present to you House Bill 549. 549, Delegate Senator Kelly requested that I put it in after she had a conversation with the Vital Statistics Division of the Maryland Department of Health. They requested this bill. So this bill basically deals with birth certificate for newborns who were carried by gestational carriers. In these cases, the intended parents are required to get an order of parentage by applying to a Maryland court of proper jurisdiction. Following the birth, the families need birth certificates for these children. It is the purpose of House Bill 549 to establish the information which the intended parents and the attendant obstetrician or midwives must submit to the vital records for preparation of such a child's official birth certificate. This bill is required because the parents need a birth certificate, and there's no other way to do it, and the department requested it so that they can issue regulation. It also requires the categories of information to be submitted to the vital records for preparation of the child birth certificate, including the delivery that it was done by gestational carrier, the identity of the gestational carrier, also any relevant medical information regarding the gestational carrier, and the information regarding the intended parents. So basically, the health department is required to adopt regulations, including the sealing of the forms and the registration of the certificate of birth in accordance with the court of law. That's all it does. And it's needed in order for the department to provide this birth certificate to these parents. Thank you so much for giving me your attention, and I hope you give it a favorable report. Thank you. Next, we have Ms. Jennifer Fairfax.
Good afternoon. Thank you, Vice Chair Penny-Melnick and Chairman Pendergrass and the members of this committee. I am an adoption and ART, Assisted Reproductive Technology attorney licensed in Maryland, DC, and Virginia. I've been practicing in this area for about 20 years and have been handling surrogacy cases for about that long in Maryland. I am speaking in support of this bill because what it does is it streamlines and makes much more efficient a process that is really being done various ways by different hospitals with different reporting information. I have actually spoken with Vital Records and worked with them regularly and know that this bill will make things less expensive, more efficient, clearly making the process straightforward for everybody. So each hospital administrator, medical professional working with the gestational carrier, the intended parents knows exactly what needs to be reported, and so that we can get birth certificates with the child's legally recognized parents on it. All of these cases do come with a court order that's issued pre-birth by our courts, which dictates certain information. But this bill is very much needed in order to really make this easier on the department as well as on the hospitals and administration. And I would speak favorably for it and hope that you would all find in favor of it as well. And I am available for any questions.
Thank you very much for your testimony today. Are there any questions for this panel? And if you could use the icon in the participant, I will be able to see your little blue hand. And I see none. And this concludes the bill hearing on House Bill 549. Next, we have House Bill 442. House Bill 442 is Delegate Young, and it's Suicide Treatment Improvement Act. Delegate Young, will you be so kind and get started?
Thank you very much for this opportunity to address a very prominent and rapidly growing health concern, and that deals with suicide. I want to point out right up front that this bill has been heavily amended since the version that you are looking at. In fact, it eliminates 8 out of the 13 pages. I want to extend a special thanks to Shannon Alshire from the Frederick County Mental Health Association and Quentin Askew, the president and CEO of 211 Maryland, for helping me to craft a much more realistic and targeted bill. Rather than go into all the things we've eliminated, I'm going to focus on what's remaining in the bill. And that is essentially 2 items. The first deals with counseling and assessment for suicidal individuals or individuals who've attempted suicide should not be required to have a copayment, a deductible, or coinsurance requirement applied. Those things have proven to be a deterrent to counseling. The second area deals with Maryland police training and the Standards Commission, and it requires them to provide to implement standards that will help ensure that when responding to an individual suspected of being suicidal, that A, the police officer is accompanied by an individual trained in providing counseling and assessment. B, responding officers don't use force when responding to an individual suspected of being suicidal, unless, of course, they present a clear threat to others. And C, the individual suspected of being suicidal is approached in a very calm and respectful manner. I believe the amendments that I spoke about should address the concerns of most of the opposition and the favorable with amendments you see before you. I know for a fact that MDH and the Maryland Hospital Association have revised their letters. And other groups, the Psychiatric Association and the Psychological Association, requested amendments that are covered by my amendments. Also, the fiscal note, I requested a revision, but it's not their policy to do revisions at this point. But I did get a message back from the author of the fiscal note that certainly any part of the bill's provisions pertaining to MDH would be removed. I want to talk a little bit about the importance and the rationale for this bill. The rates of suicide have steadily risen in Maryland over the past 2 decades, and particularly during the pandemic, they have increased exponentially. A June 2020 survey discovered that 40% of adults in this country are struggling with mental health and substance abuse. In 2018, Maryland lost 650 residents to suicide. That is on the average 1 person every 13 hours. And for young people between the ages of 15 to 24, suicide is the second leading cause of death. Suicide is 5 times more deadly than drunk driving. In a publication produced by NCSL, the Reversing the Rising Tide of Suicide, they identified some of the most vulnerable segments of our society. And not to anyone's surprise, veterans and first responders. Some interesting information in that publication is that law enforcement, EMS providers, and firefighters more frequently die from suicide than from their line of duty activities. That is something that is truly alarming and would substantiate why this should be a priority. One other thing in this report that I noticed that was missing is Maryland, because the report cites best practices in suicide from states around the country. Normally, Maryland is a leader on healthcare issues. So I ask you all to join me in supporting efforts that will better prevent suicide, so Maryland, once again, can be a leader and not a follower. Thank you for your time and attention.
Thank you, Delegate, and great timing. Next, we have Ms. Emily Allen.
Thank you, Chairman, Vice Chairman, and members of the committee. My name is Emily Allen. I'm the Public Policy Associate at Mental Health Association of Maryland, here in support of HB 442. As Delegate Young talked about some of the key aspects of this bill, I wanted to focus on the impact it has specifically in the time of crisis with COVID-19. Many of my statistics are in my written testimony for you to read, but there's a few that I wanted to highlight. The COVID-19 pandemic has had a very real impact on mental health and suicidality in Maryland's residents. Between March and May of 2020, during the height of our lockdown protocols, suicides in the African American community nearly doubled. Throughout the pandemic, calls to Here to Help, the Baltimore Crisis Hotline, also doubled. Specifically in Montgomery County, where I know several of our delegates are from, in a specific period of a month and a half over the summer, there were 400 residents in that county that went to an emergency room with either self-injury or reported suicidal thoughts. The research has shown us that financial hardship can be a significant risk factor for suicide attempts, and housing loss can also precipitate suicide. And as of December 2020, there are still nearly 200,000 residents in Maryland that are unemployed. And yes, this is a significant improvement over April of last year, when we had 315,000 people unemployed, but that's still 1.5 times as many people than January of 2019. And while we do also have the eviction moratorium, we all know that one day that moratorium is going to be up, and we're going to still have people that are dealing with the economic fallout of COVID-19 and struggling because of that, and those people will be at increased risk. Within this widespread increase, we need the improvements listed in HB 442 to training and workforce, specifically in those key areas that the delegate mentioned, that interact with residents that are experiencing crisis, such as law enforcement. And with these reasons, we urge a favorable report on HB 442.
Thank you for your testimony. Are there any questions for this panel? If you will be so kind and raise your hand, Delegate Bel Castro.
Thank you very much. And Delegate Young, it looks like the Maryland Insurance Administration made some recommendations in their letter of info. If you've had time to review those recommendations, can you expand on your thoughts with that?
Thank you for that question. I did read their letter, and I would say They pointed out things that are the unintended consequences of not being an insurance expert. I thought that several of the recommendations that they made certainly made sense. And I will work with the appropriate experts to ensure that we don't unintentionally exclude anyone.
Thank you.
Thank you for your question, Delegate. Next, we have Delegate Kerr, followed by Delegate Bagno.
Thank you, Madam Chairman. Delegate Lewis Young, the Department of Legislative Services voiced some disagreement with the Maryland Police Training Standards Commission regarding the fiscal note. Can you explain that a little bit, please?
Thank you. Yes, I believe that the Maryland Police Training and Standards Commission said that they thought that it would cost $70,000 annually for training, and DLS disagreed and advises that the bill's requirements can be handled with existing resources, and claims that the development of standards and procedures for providing training to law enforcement officers is actually a part of their function. Also, in that publication I referenced a while ago from NCSL, Reversing the Rising Tide of Suicide, they talked about gatekeepers for training, and they certainly identified law enforcement as one of those gatekeepers. So national models already exist on training, and those could easily be utilized without additional staff or planning or authoring new training policies.
Thank you, Delegate. Thank you, Madam Chairman.
My pleasure. Delegate Bagno, followed by Delegate Hill.
Thank you, Madam Chair, and thank you to the bill sponsor. This is really an important dialogue. I'm just trying to figure this out because I know that you mentioned that the bill is heavily amended, and I wanted to give you an opportunity to respond to the opposition by the Hospital Association as to whether the amended bill addresses their concerns about the discharge plans and also about duplicating the patient bill of rights.
Okay. I have had a conversation with a representative from the Maryland Hospital Association since they wrote that letter, and they claim that my amendment covered their concern. I'll let them speak for themselves, but that was the conversation I had, because the part of the bill that addressed their responsibilities was removed from the bill to simplify the bill.
Thank you very much. Thank you, Madam Chair.
You're welcome. Delegate Hill. You have to unmute yourself.
Okay, yes, I'm trying to reach it. Thank you very much, Madam Chairman. Sorry about the delay. Delegate
Not a
Lewis
problem.
Young, very much appreciate this legislation. My question is, the police officer training, I understand that training is already, sort of paid for, but do you have any idea what their current standards are in Maryland for dealing with suicides? I'm particularly looking on your bill where it says they have to be accompanied by an individual trained in providing counseling and assessment, which would be assuming that they know that the call is a suicide before they arrive, and that they can't use force unless there's a threat of harm to others. And I don't know, can you speak to, or either of you speak to, what the current standards are? And at least anecdotally, police officers talk about knowing that someone's going to hurt themselves and maybe shooting to disarm them, or using force so that they don't hurt themselves. So it's not just in cases where they might be harmful to others. Your bill, if I understand it, would not allow them to use force to stop a suicidal person from hurting themselves also. Am I understanding that right?
I think your question has multiple questions embedded.
They only get one.
You only get one question. You answer the
With
best
multiple
one.
parts, multiple parts.
Okay. Let me talk to the one that I think has the most opportunity for some change. And that is a police officer is accompanied by an individual trained in providing counseling. If the bill needs any further work, it might be right there, because I'm not sure that's always realistic. In a smaller municipality, in a rural area, is a police officer going to have that accessibility to an individual with that kind of training? So in this age of increasing telehealth options, I think that perhaps that area could be clarified, if not amended, to say that the police officer would have access, even if it's audio access, to someone with a specialty in providing counseling and assessing. Otherwise, that could be very onerous.
All right, we're going to, since it's one question, the rest of it you could do offline, Delegate Lewis. You can meet with Delegate Hill or speak on the phone. Thank
Okay.
you. Are there any other questions? Because we have a long agenda. Seeing none. Any more? No? Thank you so much, Delegate, and your panel. Next, we have a
Thank you.
panel of unfavorable or pleasure. We have Mr. Drew Pate and then Ms. Erin Dorian. Mr. Pate, good afternoon. Will you please get started?
Thank you. This is Dr. Drew Pate. I'm the chairman of psychiatry at LifeBridge Health. I appreciate the opportunity to meet with you all today. As in working with my colleague at the Maryland Hospital Association, had initially registered opposition based on the original format of the bill. And due to the amendments, I no longer have any opposition to speak to. So I am available if there are any questions as a child and adult psychiatrist, certainly around the matter of suicide, but otherwise I do not have any additional statements to offer.
Thank you. Those are magic words for a delegate. Thank you so much. Ms. Erin Dorian.
Thank you, Madam Chair, members of the committee. My name is Erin Dorian, and I'm the Director of Government Affairs and Policy at the Maryland Hospital Association. You do have my written testimony in opposition to some aspects of HB 442, but as Delegate Lewis Young said, we appreciated the opportunity to meet with her after the amendments were offered, and with those amendments, we can withdraw that opposition. Maryland hospitals and clinicians are committed to providing the most appropriate care for individuals who are suffering from a mental illness so intense that they no longer want to live or have attempted to take their own life. MHA is supportive of efforts to ensure access to care for all behavioral health patients and policies to improve interactions between individuals in crisis and the police. So I can give you back at least a minute of your time, and we are here to answer any of your questions, but we do withdraw that opposition.
Thank you very much for your testimony today. Are there any questions for this panel? We have Delegate Collison.
Thank you, Madam Chair.
My pleasure.
And I want to thank Mr. Pate and Ms. Dorian for being here. So I heard we withdraw our opposition. I'm wondering if I would also hear that you're now supporting the bill, the legislation, and either one can answer.
Thanks, Delegate Collison. I think when we initially gathered our members to talk about this bill, we really focused on the pieces of the bill that did affect facilities. But we will be taking another look at the bill. We definitely support the intention and the concepts. And I know that Delegate Lewis Young, will be working. Sounds like you'll be working with some others on amendments, and so we'd be happy to join that conversation.
Great, thank you very much.
If we're needed.
Thanks.
Any other questions for this panel? Seeing none, this concludes the bill hearing on House Bill 442. Next, we have House Bill 605, Delegate Kipke, Veterans, Behavioral Health Services, Mental Health First Aid. Delegate Kipke, good afternoon.
Delegate Kipke is not in the room with us at this moment. I don't know if you want to come back to him. I just resent him the link. Vice Chair, you're on mute.
Thank you very much. Why don't we get started with Mr. Dan Martin while Delegate Kipke joins us, because Mr. Martin is actually in favor. Mr. Martin? Is he here?
So Mr. Martin is being replaced by Margot Quinlan.
By Margot, okay.
Yeah.
Ms. Margot Quinlan, will you please get started? Good afternoon. Okay, if you can unmute yourself, please. Thank you. If you can get started with your testimony, we can hear you.
Okay, great. Well, thank you.
Okay.
Yep. Thank you, Chair, and thank you, members of the committee. My name is Margot Quinlan. I'm the Director of Youth and Older Adult Policy at the Mental Health Association of Maryland. And we are here in support of House Bill 605. This bill requires the Department of Health to include mental health first aid training among the behavioral health services it coordinates for veterans and their families. This bill does not require any additional funding. The fiscal note says that the bill currently codifies current practice, and we think technically that's probably true. But what it really does is encourages the Department of Health to direct mental health first aid more proactively to more veterans and their families. Mental Health First Aid is a world-renowned evidence-based program that teaches how to recognize and respond to a person with a mental health concern or crisis. The course includes information about various behavioral health disorders, risk factors and warning signs of mental health concerns, and a 5-step action plan to help someone in crisis. The course also has a veterans module, which includes a discussion of military culture and mental health, specific risk factors faced by service members and their families, and community resource information and more. And now, in full disclosure, Mental Health Association of Maryland has played a central role in adapting the mental health first aid program for the US. And since 2009, our organization has facilitated the statewide Mental Health First Aid Maryland program. In that time, we've trained over 36,000 Marylanders, including over 700 instructors. And we included a copy of our 10-year report in the testimony that we submitted. So we are happy to answer any questions that members of the committee may have after they have a chance to look at that report. We do all of this through a core of instructors and master trainers who primarily deliver free and scholarship-based trainings through a state grant, ensuring that no one seeking mental health first aid is turned away. At Mental Health Association of Maryland, we are mission-driven to get this training to as many folks as possible. So to the extent that this bill will help direct the program to more veterans and their families, we are in full support and urge a favorable report. Thank you.
Thank you so much for your testimony. Next, we have Mr. Brian Smith. Mr. Smith?
Yes, good afternoon, Chair Pendergrass, Vice Chair Pena-Melnick, and members of the House Health and Government Operations Committee. My name is Brian Smith. I'm a post 9/11 combat veteran. I have PTSD. I've lost friends to the scourge of veteran suicide, and I'm here today to offer my support for House Bill 605. Last year, when a friend of mine, a veteran, took his life, he left friends, family, and 2 unanswered questions asked by many of us that knew him. How could I have known, and what could I have done? Thus, the challenge and the solution are rooted in knowledge and empowerment. As you know, this legislation implements a mental health first aid program for veterans and their families. This training program will enable veterans and their immediate family members to identify and respond to signs of mental illness and substance abuse disorders. So why is this so important? 2.7 million service members have been to the war zones of Iraq and Afghanistan since 2001, and over half of them have deployed more than once. In fact, over 400,000 of them have completed 3 or more deployments. The Substance Abuse and Mental Health Services Administration estimates that almost 20% of these service members have post-traumatic stress disorder. That's nearly 500,000 veterans. And as we know, 20 veterans die each day by suicide. Many times that number of Americans have borne the costs of war as spouses, parents, children, and friends that coped with their loved ones' absence, mourn their deaths, or greet the changed person who often returns. Many Iraq and Afghanistan veterans face a life of disability due to the physical and psychological injuries they sustain in the war zones, and many more live with physical and emotional scars despite the lack of disability status. Sadly, due to the stigma, many veterans with mental health problems do not seek help or they delay seeking help. Even when people decide to get help, it's frequently—
Don't worry, sir. You can have a few more minutes. Delegate Kipke's not here yet. You can go ahead.
Okay, I'll be 30 seconds. Even when people decide to get help, it's frequently after many years of delay. The longer a person waits to seek help, the more difficult their recovery can be. And all too often, these veterans take their own lives. So when it comes to those two questions, how could I have known? Mental health first aid training provides awareness of mental health warning signs. And what could I have done? This training provides actionable recommendations on effectively connecting veterans with the appropriate professional caregivers. So what can we do here today to fight for our veterans' lives? We can move this bill forward. I respectfully request a favorable report for House Bill 605. Thank you very much for your attention.
Thank you for your time and for your service, and I'm so sorry about the loss of your friend. Are there any questions for this panel? Speaker Pro Tem Semple Hughes.
Thank you, Madam Chair, and thank you to those who testified on this bill. It is very important work. My question is for Margot Quinlan. I just wanted to ask, of the 36,000 individuals that have been trained in Maryland, how many would you say that are women veterans? Reason I'm just asking and narrowing that a little bit is because our Women's Caucus in the General Assembly is heavily focused on women veterans and having, specific efforts towards that end. And do you see that as a population that's still not getting service? And if so, can this bill help in that manner? Thank you.
Yes, that's a great question. And I would have to follow up with you, which I can do this afternoon as far as the specific numbers of people served. But I think you're right. I mean, I think there is a gap there. And we do see this bill as really expanding this program, which is already having a pretty wide impact, but we really could go a lot wider and really be supporting more veterans. And so we see this as just a great avenue to increasing the efficacy. But I would, point folks to that 10-year report in our testimony, but I will follow up with you and I can follow up with anyone else with specific numbers and information to help with that question because it's a really critical one.
Thank you so much for your answers. Next, we have Chairman Pendergrass.
Thank you, Madam Chairman. I was listening and thinking about how this program works together with veterans benefits programs through the VA. Is there a connection? Do they fit together? I don't know which of you is best able to answer this, but it seems like this is one of those zones where you have two places that people could be looking to help, and I'm wondering how they work together or don't.
I can take a stab at it as a—
You can try it. You can try, Mr. Smith.
As a disabled veteran with PTSD, mental health first aid training is not something offered through the Department of Veterans Affairs, which is unfortunate. They have other in-house type of services. I think the thing that's even more unfortunate is that so many of our post 9/11 veterans with service in Iraq and Afghanistan have not crossed the threshold of even becoming eligible for Department of Veterans Affairs services. So there's a large unserved population out there that could benefit from it. There's a large Veterans Affairs population that probably could as well, but unfortunately, mental health first aid is not something that we can avail ourselves of, and that's why I was so excited to see this bill being offered. and to bring it, because it's not only veterans, it has applicability beyond the veterans community, but some of the underserved populations that were alluded to. Women veteran suicide is bad. It's equally, if not worse than the men's manifestations of it. It's a bad situation, as well as some of our most deserving veterans who've perhaps, as I said, have not crossed the threshold of becoming eligible for VA services. So this is really something that I was excited to see that Maryland can do for Marylanders and keep some of us alive.
Thank you, and thank you, Madam Chairman.
My pleasure. I know Delegate Kipke's aide is here and she would like to testify. Is that correct?
Yes. Thank you, Madam Chair. My name is Emily Gilliland. I'm Delegate Kipke's legislative aide, and I'm here to present on House Bill 605. This bill passed the Senate committee unanimously last year, the same day as the bill hearing. Apparently, we ran out of time on the House side due to COVID last year. So as stated before, this bill is very timely for veterans as they deal with mental health, especially during the COVID crisis. There are 15 different veteran groups that support this bill. And there's two key points to mention on this bill. It requires the department to include mental health first aid training among the behavioral health services in which Maryland Department of Health provides service coordination for eligible veterans. It consists of training for veterans and immediate family members, and it focuses on how to identify and respond to signs of mental illness and substance abuse. And second is that there is a reporting requirement that shows how many veterans and their family members are being trained. It does not teach people how to treat or diagnose mental health, but how to offer initial support until professionals are available during the crisis or the crisis is resolved. Thank you.
Thank you. Are there any questions? Seeing none, thank you so much today for your testimony. We really appreciate it. This concludes the bill hearing on House Bill 605. We were supposed to have House Bill 462 that has been withdrawn. So members, we're now on to House Bill 710, Delegate Krebs, Maryland Medical Assistance Program, Dental Providers and Dental Students Reimbursement. Good afternoon, Delegate Krebs.
Good afternoon. How are you?
Good. Thank you for asking.
Moving along very quickly here. Thank you for that. House Bill 710 is Maryland Medical Assistance Programs, Dental Providers, and Dental Student Reimbursements. Basically, I'm going to leave most of my time for the advocates, but what does this bill do? Basically, it's going to continue to open. Excuse me, getting feedback. There you go.
Yes.
Basically, it's going to continue to open the door with Medicaid so that our dental students can have some increased exposure to Medicaid services for the dental students and incentivize those students to go into careers that serve those same populations. The bill essentially codifies what's permissible in current law. And it's a little, I know we have some opposition, and I think some of it is just whether the language isn't clear or whether or not, I don't think it's a philosophical difference because it's already in law and permissible under current law. So we all know, especially during COVID, that many areas of the state are lacking dental services for Medicaid, those on Medicaid, especially in our rural areas and some other areas. So we're trying to open the door for more exposure for our dental students and more opportunities. So again, the fiscal note clearly says we're just codifying what is already permissible. Also, the Department of Health bill says the same thing. So those who are in opposition, I know we all are on the same page of knowing we need some additional opportunities for these students. So hopefully we can work with the opposition and get clear what the language is meant to say and what it really says versus what I think is maybe a misconception. So I'm going to confer my additional time over to the advocates of the bill and let's work on this together.
Thank you, Delegate Krebs. Next, we have Ms. Kaylin McDonough. Good afternoon.
Good afternoon, Delegate. I'm sorry, I'm just getting my testimony up. Chairman Pendergrass and members of the committee, my name is Caitlin McDonough. Why this is not going. Excuse me, sorry, I apologize. I couldn't get off the full screen. My name is Caitlin McDonough. I'm here today representing Benefis. Benefis is a dental support organization that provides non-clinical support services to dental practices throughout the United States. In Maryland in particular, we support 9 practices that primarily provide Medicaid services. And given the Medicaid dental benefit in the state, that also means we primarily treat children. And I wanted to go into the origins of House Bill 710, which we support, and we see it as a pretty simple bill. And I think we see it in the same way that's reflected in the fiscal note and the testimony from, or the letter of information from the Department of Health, that this bill is just clarifying an ambiguity in current practice about whether student externs from a dental school can, under supervision, can provide services to Medicaid patients. They are already able under law to provide services under supervision. They're exempted from scope of practice limitations and licensure requirements, but there is an ambiguity in the Medicaid regulations that makes it a little bit unclear on whether they can treat Medicaid patients. And basically what the regs say is to treat Medicaid patients and provide dental services, you have to be a licensed dentist. And it is unclear whether that definition of licensed dentist includes a student acting in an educational program under supervision. So that's all we're seeking to clarify here. And how it came up is we, had some very, very preliminary conversations with the University of Maryland Dental School about possibly partnering with them as a community partner on their existing externship program. They have students who provide services in federally qualified health centers, and we thought we might be able to provide similar opportunities and also help expose those students to both Medicaid populations and pediatric services, which are both areas they don't get a lot of experience in necessarily in their kind of traditional dental education. And, throughout that process, the question was raised whether, we were permitted to treat Medicaid patients. And after going back and forth with the department and with Maryland Medicaid for a couple years, actually, we thought the clearest way to address it would be to kind of get some clarification in statute and just clear up that matter. So that's the origin and the intent of the bill. But I think it's also really clear to go over what the bill does not do. And this bill does not affect or expand scope of practice for dentists, dental practices, dental students, or anyone else. It doesn't expand the type or amount of dental or Medicaid services that would be provided in Maryland. It doesn't require that any dental school, any student, any dentist, or any practice participate in an externship. And it doesn't set any additional, it doesn't remove any current parameters for those externships that are currently in place. All it does is clarify this one kind of ambiguity around Medicaid patients. And the reason we want to, hopefully open the door to pursue these type of externships is we know that when students are exposed to this type of service during their educational period, they're much more likely to go on to treat those patient populations and work in those geographic areas that have a high Medicaid population. So that's all we're hoping to do. It's something we do in other states. We partner with Virginia Commonwealth and have a very similar program. We're happy to work with the, MSDA and some of the other opposition to address some of these guardrail issues. My only concern would be this bill is particularly addressing this Medicaid issue. If we start putting a bunch of new requirements in this bill, how does that affect some of our existing externship programs in the state? And are we then treating Medicaid patients differently? I don't know if I'm on my time now.
I think now you're on your time, I believe.
Okay, and I'm going to wrap up pretty quickly. I am joined by Ronnie Coleman with Benefis today, and I think he can give a little more specifics on, the programs we do in other states. And those include, based on the school's parameters, a lot of requirements, curriculum requirements, supervisory requirements, liability requirements that are all kind of outlined in some of the opposition's bill. Testimony. But what we see is those are things that are set by the school and the practitioner and within the externship program and not necessarily set in statute. So my understanding is currently a dental student could practice under an externship in a private practice, so long as the patients there are being treated under private insurance or paying out of pocket. And that practice could bill in the kind of their day-to-day billing. So we would just want the same parameters and same requirements to be in place for a similar program where the students are providing services in a practice that primarily serves Medicaid. And, you know, again, to Delegate Grubbs's point, we're happy to work through it. I think I'm already looking at some language that might be helpful. I just would caution the committee that we not unintentionally start limiting some of our current externships because of maybe some perceived expansion of scope under this bill. That's not the intent of the bill. And we would agree with legislative services on their reading and the fiscal note. So I'm finished and I'm happy to answer any questions, but we do advocate for a favorable report on the bill.
Thank you. Mr. Ronnie Coleman, good afternoon. Will you please get started? Mr. Coleman?
Yes, hello. Sorry about that.
It's
Can you hear
okay,
me
it
now?
takes time. Yes, we can hear you clearly. Good afternoon, sir.
Good afternoon. I'm Director of Government Relations for Benevis. We support Porter and Pine Dental in Maryland. We serve about 20%, pre-COVID, we served about 20% of the Maryland Medicaid dental beneficiaries, and in Baltimore, about 40%. So we have a lot of experience in this area. Caitlin pretty much explained most of this issue. I just want to give a little bit more color. When the conversation was going on between our chief dental officer and the University of Maryland Dental School, it became clear to me that the University of Maryland program director was surprised that we could not proceed because we found out about this Medicaid limitation. He had thought all along that they'd been seeing Medicaid because they partner with federally qualified health centers. And I believe, and I think I figured this out later, that he didn't necessarily realize that those adults that were in the FQHCs were not Medicaid. And that's why he thought that he was seeing Medicaid, because you don't have an adult Medicaid dental benefit. So anyway, I should mention that we have some experience with community-based experiential learning programs. We've supported programs at Indiana University Dental School and Louisiana State University Dental Schools financially and in kind. Those programs work with Title I schools and vans where dental students actually provide exams and place sealants. In Indiana, we're actually in the process of having one of our dentists affiliate with IU Dental School so that dental students could come to our office and do work. But of course, COVID happened. And then as Caitlin mentioned, in Virginia, we actually participate in their externship program. One of our dental leaders became affiliated with the university, and it was not a heavy lift and was able to create a very popular program for interested students at VCU. And I think the faculty appreciate it as well. So I'll just skip to the end and just say in closing, I just want you to know that we believe that opportunities for interested dental students to appreciate the kind of need that exists in minority and rural communities might translate to an interest in safety net dentistry. And that again, we're not interested in creating any externship programs or rules. We just want to participate. We just think that this population needs to be included in the experiential learning for dental students these days. And so I appreciate your time, and I'm happy to answer any questions you may have.
Thank you very much for your testimony today. Are there any questions for this panel? If you would just raise your hand at the participant icon. Delegate Hill.
Thank you. Mr. Coleman, can you explain why it is that your Medicaid providers aren't simply applying or charging Medicaid as if they were providing the service? The fact that the student is providing the service is not something they have to report on the bill because the student is not licensed to practice. So that's what providers do. You just bill for the service. You don't say a student did it. So I'm confused about why we need this and why your providers aren't just saying, Doctor.
We're on the same page. I've said the exact same thing from the beginning. We were told that this particular language in the Medicaid regulations precluded us from participating in the program. We looked into it with the dental board, we looked into it with Medicaid, we tried to change it with Medicaid just to be clear. But all along, we felt that this was just some technicality that was being misconstrued. So what you're saying is exactly what we think. We should have been able to participate from the beginning. Has nothing to do with dental students billing for Medicaid, because as you know, hygienists don't bill for it, DAs don't. It's the doctor that bills, and it would be the exact same thing with dental students. So I could see the quizzical look on your face. We've had that for 3 years.
Because your bill doesn't do that, but I'm done. Thank you. Maybe we can talk offline. I'm not.
So just to follow up on that line, Delegate Krebs, have you requested an AG letter?
Where am I? Sorry about that. No, I have not. So the AG letter would just basically ask if they would allow for this. We can
They
do
will
that.
basically ask for for them to interpret what that statute says. Yes.
We can do that.
Okay. Are there any other questions for this panel? Seeing none, thank you very much for your testimony today. We appreciate it. Next, we have Mr. Charles Doran and Mr. Daniel Dorothy. Good afternoon, Mr. Doran.
Good afternoon. Thank you, Madam Chairwoman, Madam Vice Chair. Charles Doring, we've met many times before. I'm a general dentist in Rockville, Maryland. I'm the Legislative Affairs Committee Chair for the Maryland State Dental Association. I'm a provider in the Maryland Medicaid Maryland Healthy Smiles program, and I'm also on the Dean's faculty at the University of Maryland. And I do think I'm looking forward to the Attorney General's information. As a teacher at the dental school, I have students come on a rotation, a geriatric dentistry nursing home rotation, fourth year students, and they gain a lot. But they're with me side by side. They're doing auxiliary tasks, and I'm supervising. Not everyone's a great teacher, and we do need, in any type of bill like this, supervision and vetting by the home dental school for that dental student. So, in talking with Dean Mark Reynolds at the dental school, when students do perform procedures at the dental school, it is billed by the supervising dentist. So just to be clear on that. So for these reasons, I recommend an unfavorable report on House Bill 710. Thank you.
Thank you. Mr. Dorothy.
Thank you, Madam Vice Chair, members of the committee. Dan Doherty here on behalf of the Maryland State Dental Association. Much of what the testimony was in favor of the bill relates to facts and issues of which I am currently unaware. My concern and my client's concern with the bill is that there are no parameters set out whatsoever. It doesn't prescribe what year the student's supposed to be enrolled in, whether it's a first-year dental student or a fourth year. Doesn't prescribe what procedures they may or may not do. It doesn't set out how there is any regulatory oversight by the State Board of Dental Examiners. As Dr. Doring indicated, there is no provision dealing with vetting the supervising dentist as to whether or not they are skilled in training dental students. And there are a number of other gaps in the bill that gives us great concern. Our efforts to try and find out about the program that was alluded to in Virginia was unsuccessful to find any real information about it. We went through the board, we went through the dental association down there, and no one seems to know about this externship relationship. So there are great concerns. There appear to be great gaps in the facts that we've been able to gather to coincide with what the proponents indicate. And because of all of these ambiguities and concerns, we request an unfavorable report.
Thank you. Are there any questions for this panel? Seeing none, may I have a suggestion. Will you be so kind and schedule a Zoom call with the sponsor and try to, see if you could work it out before it goes, it's assigned to subcommittee, and also request the AG letter, please. Okay, Seeing no other question, this concludes the bill hearing on House Bill 710. Next, we have House Bill 547, Delegate Robin Lewis, Maryland Medical Assistance Program, dental care and oral health exams. Delegate Robin Lewis, good afternoon. Delegate Lewis? Okay. We have, we're going to go to a favorable witness. We have Mr. Charles Doran while Delegate Lewis comes on board.
Okay, thank you very much again, Madam Vice Chair, Madam Chair, members of the committee. Charles Doring here, again, general dentist in Rockville, Maryland, and with the Maryland State Dental Association. And also a provider, proud provider of our Maryland Healthy Smiles program. And matter of fact, I was just placed on the Maryland Healthy Smiles Provider Advisory Board. So I'm very honored to do that. Dental exam and prophylaxis. Prophylaxis is defined as activities that prevent disease, especially with specific means and against specific diseases. Unfortunately, 90% of the treatment I provide is preventable. And it's removal of the bacterial biofilm around the teeth and gums. This biofilm causes dental caries and causes periodontal gum disease. Frequent prophylaxis depends on a variety of factors, including the patient's ability to clean their teeth, diet, systemic diseases, and salivary flow. Some patients are on an 18-month checkup schedule, and others come in every 2 months. House Bill 547 lets us provide better care for our patients in the Maryland Healthy Smiles program. Life does not occur on a 6-month schedule or routine. Things happen. School, pre-surgery, a dental clearance, say for organ transplant, pregnancy, deployment of a family member in the military. These have all occurred in my office. Most dental plans allow 2 dental prophylaxis visits per calendar year, and that does not change in House Bill 547. Since dental plans, actuaries calculate 2 visits per year, allowing the needed dental visits at 120 days or more interval, as in this bill, it will allow us to provide better care. So I ask for a favorable report on this House Bill 547. Thank you.
My pleasure. Great timing. Mr. Dorothy?
Thank you, Madam Chair, members of the committee. Dan Doherty here on behalf of the Maryland State Dental Association in support of House Bill 547. As Dr. Doring indicated, this bill does not change the coverage under Medicaid to more than 2 times a year. It merely sets up a more flexible interval between those visits. So under the bill, rather than having an arbitrary, you can only go a second time after 180 days. This provides that you can go twice a year with no less than 120 days as an interval. This provides flexibility for students who have needs to get examined before beginning a school year, for pregnant mothers, etc. This has been the standard in the commercial dental plan world since 2012, when this legislature passed legislation for the commercial insurance that reflects what House Bill 547 does for Medicaid. This bill will not increase the number of visits. It does not increase the coverage. It just merely prescribes a more flexible interval between those 2 visits. And we would urge a favorable report.
Thank you for your testimony. Next, we have Ms. Ashley Black. Ms. Black, good afternoon. Will you get started, please?
Sure. Good afternoon, Chair, Vice Chair, and members of the committee. My name is Ashley Black. I'm the lead attorney for the Access to Health and Public Benefits Project for the Public Justice Center. We support policies and practices that promote the overall health of Marylanders struggling to make ends meet. We strongly support House Bill 547. Oral health access has been an advocacy priority for us for many years, since one of our clients' children, a 12-year-old named Diamante Driver, died of an untreated tooth infection in 2007. We believe that right now is the time to consider ways that we can get consumers quicker access to health services, particularly preventative services. Creating this simple flexibility in Medicaid preventative dental coverage now could mean less emergency room visits for dental issues later for beneficiaries. I'm thinking in particular about workers and those who may not have access to childcare and really need that scheduling flexibility to address what might become an undiagnosed chronic dental issue. And when those issues are not addressed, they can lead to severe dental pain and potentially an infection. And I'll just close by saying that the more we can do as a state to put Medicaid beneficiaries on equal footing with private insurance consumers for necessary and preventative services, the better our overall oral health outcomes will be. So thank you, and I urge this committee to issue a favorable report.
Thank you for your testimony this afternoon. Ms. Robin Elliott. Ms. Elliott.
Great. Good afternoon. I'm here today on behalf of the Maryland Dental Action Coalition, very much in support of this bill. You've heard a little bit about the bill, and I just wanted to circle back to the core language in the bill. So we know that Medicaid covers 2 preventative services a year, just like private insurance. The bill doesn't change that. It would just create a little more flexibility as the timing of the services. So somebody could come in a little bit early. We've heard this really commonly from parents who are trying to align the appointments of all their children and how challenging it is. So overall, this will provide a little more flexibility in Medicaid, and it's the exact same flexibility that the Maryland General Assembly extended to those with private insurance in 2012. Thank you so much.
Thank you very much. Next, we have Ms. Wenzel Carter.
Good afternoon.
Good afternoon, sir.
I have had a 40-year career in public health, most recently with Montgomery County's Public Health Dental Program and Mary Center, a nonprofit based in Washington, D.C. And I would just like to say that for patients in this setting, they need the flexibility that's on par with what private insurance patients have. For many of these patients, dental visits, this may be the first time they've had access to dental care, and it takes a lot of reinforcement to get them accustomed to coming in for dental appointments and having the flexibility to come in perhaps a little bit not locked into a 120-day time frame would be better for them, better for maternity patients, as we call them. Or if someone discovers that they are pregnant, this will get them off to a good start in their pregnancy. So I would urge a favorable report from the committee.
And thank you, sir, for your practice in Maryland. We appreciate it. Next, we have Delegate Lewis.
Thank you so much, Madam Chair. Esteemed colleagues, Robin Lewis on behalf of House Bill 547. Forgive me for joining you late. I was in ECM. So you've heard a little bit. I walked in as the other bill proponents were testifying. So I know you've heard a little bit about this bill. As a sponsor, let me throw in my 2 cents. So this is a bill that essentially expands dental care access for the people of Maryland. I think I speak for all of us on our committee when I say that one of our driving missions is to increase all healthcare access for our people. This bill addresses a small piece of the access picture in making sure that folks who have state regulated plans under Medicaid have the same benefits as people who have private plans. Beyond that, you've heard all the testimony. I won't need the whole 5 minutes to just appeal to your sense of fairness, to remind you of your mission to protect and expand healthcare access. And with that, ask for your favorable report for this common sense health equity bill. Thank you.
Thank you. Are there any questions for this panel? First, we have Delegate Collison, followed by Delegate Bagnall, then Delegate Krebs.
Thank you very much, Madam Chair. And thank you for this bill. I think it's a terrific bill. I love it. So I'm looking at the letter of information from the Department of Health, which talks about a significant increase in the state expenditures. And I guess I'm puzzled because not sure where if correct me if I'm wrong, if youngsters are getting our folks are getting the service when they need it, the prophylactic service, the need for more services might actually go down. So, and what I heard the proponents say is that the number of visits didn't necessarily go, the number of prophylactic visits didn't increase. So can you respond to the health department's rationale for the pretty significant increase in cost? And whomever is best suited to do that.
Sorry, I muted myself. Thank you so much, Delegate Collison. Yes, I'd like to hand that question over to the best person to answer, and I think that might be Robin Elliott.
Certainly. So thank you, Delegate Lewis. And we do know, and there's lots of research data that shows investment in preventative services results in savings later. I did pull just one piece of information. We have more, and I'm happy to share this with the committee. But in the department's annual legislative report, it shows on oral health in 2017, it shows, it's really great, an increase in preventative services visits for children goes up by almost a whole percentage point between 2012 and 2016. And then correspondingly, there's a decrease in the level of restorative visits by a percentage point. Now, we don't know if those are exactly correlated or associated, but I think that does demonstrate a pattern that investment in preventative services does really, especially in dental, really make a difference in avoiding costly services in the long run.
I hope that answered your question, Delegate.
Thank you very much. Yes.
Thank you. Next, we have Delegate Bagnall, followed by Delegate Krebs.
Thank you, Madam Chair. And thank you very much, Lewis, for bringing this really important equity bill. I just have a question because I'm aware that the Maryland General Assembly took action to give this flexibility to private insurance nearly a decade ago. Is there anyone who can speak to what the level of support was from the General Assembly when we took this action for private insurers?
Great question. That would predate me, and I would
me as well.
Ask Madam Chair if you would indulge me and let someone who knows the history better answer that.
Okay, so why don't I, thank you so much. I appreciate it. So Chairman Pendergrass.
Would you kindly mute?
You're muted.
Yourself, ma'am.
There, sorry, we don't usually answer
Lewis,
questions.
Can you mute yourself? Thank you.
But I'm going to, because I was here and we did this when Mike Bush chaired Economic Matters. And we did the private insurance. And it was very clear that there were no more visits allowed for prophylaxis before that than after that. It was just a matter of flexibility. And my question that Delegate Collison asked was how in the world, mine was less polite, did the department come up with an estimate of how much money it was going to cost when basically we were not changing the numbers of times this was performed in a given year? So I think that unfortunately we may have to ignore what the department has to say on this bill.
Thank you. Thank you so much. So next we have Delegate Krebs.
Oops, how are you? Thank you. And several of my questions have been answered, so I can limit it down to the one instead of putting 3 questions in one big, long question.
We are so grateful.
With regard, I agree with what the chairman just said before us about the fiscal note from the department, but also Department of Legislative Services had some illustrative purposes some information about the increases. And I'm still trying to figure out why, if it's only increased flexibility, why this is going to matter. And then, and if somebody that's a provider might be able to answer this, it currently, Medicaid eligible children are able to receive dental preventative care at frequencies less than 6 months under the early periodic screening and diagnosis, as long as they're medically necessary, according to COMAR. So what situations would they be doing this and it not be medically necessary? And I can't put my arms around what's actually happening and why this fiscal note is so high, even for illustrated purposes from the Department of Legislative Services. I'm not sure I understand why. If the increases if you don't have more visits.
Right. Thank you, Delegate Krebs, for your question. I have to say, that's an excellent question. I don't feel I can adequately answer. And I wonder if there are any other of my panelists who could.
Delegate Krebs, I've got some information. So the once every 3 months are for children in a specific program called REM. And all the other children and adults are at twice a year. Making it a little bit easier, a little bit more flexibility in the timing is going to result, I think, in a small increase in the number of people getting preventative services. And that's a good thing. But I think that the relative number is probably pretty low. And so I noticed that Legislative Services did say, for illustrative purposes, if it was a 1% increase, which I think would be incredible if we got 1% more children to get their regular preventative services, it would be about 139,000 in general funds. So.
Thank you.
Thank you. Any other questions for this panel? Seeing none, thank you very much. This concludes the bill hearing on House Bill 547. Thank you so much for being with us today. Now we have House Bill 548, Delegate Lewis, Human Services, Trauma-Informed Care, Commission and Training. Good afternoon.
Good afternoon, Madam Chair, esteemed colleagues, Delegate Robin Lewis on behalf of House Bill 548. Thank you for your attention and indulgence. So this is, I'm kind of on a roll, esteemed colleagues. I'm on a health equity roll this year. And what you have before you in House Bill 548, the Trauma-Informed Care Commission bill, is a health equity bill. This is designed to expand health and well-being for the people of Maryland. I'll take you back to a quote from that great Marylander, Frederick Douglass, who said, "It is easier to build strong children than to repair broken men." The Trauma-Informed Care Commission bill will allow us to build strong children and create a healthier population to give people the hope and the health that they deserve. What does this bill do? This bill will create a statewide commission on trauma-informed care. The commission will operate by making recommendations, building a statewide strategy on this concept of trauma responsive care, trauma informed care that will improve the health, well-being, and life outcomes for children and youth around our state. I should focus for a minute on definition of terms. We talk a lot loosely about trauma, and you've heard in this committee before the term adverse childhood experiences. Nitty gritty. Think of it this way. We all learn to ride a bike. We all experience falls and cuts and scrapes, and we all know the joys of Band-Aids. But those cuts and scrapes we got falling off of our bikes created a wound that healed. A trauma is a wound that doesn't heal. An adverse childhood experience is an injury that doesn't heal all by itself. Trauma-informed care is an approach, not just in medical science, but in delivery of services like through state agencies like social or housing services, education, that help heal those wounds, especially the ones you can't see. A trauma or an adverse experience, or ACE, could be anything like hunger. It could look like homelessness. It could look like exposure to domestic violence. And those sorts of exposures can be healed and treated with very focused and deliberate services. So I won't go deeply into a recitation of data to persuade you here, because I have other excellent panelists who can do that. I won't pretend to speak for people who have the lived experience of trauma or adverse childhood events, because I have amazing panelists who will do that much more movingly and persuasively than I can. You can look at my testimony, you can look at other written testimony. There is no opposition to this bill that I'm aware of. There is broad support for this approach. I think the reason for that broad support is that throughout our state, trauma and adverse experience know no geographic boundaries, no racial or socioeconomic barriers. In fact, chances are every single one of us sitting on this committee has had some experience of harm. Those of us who are lucky enough for to have support could overcome it. Our duty is to extend that same opportunity for support in the work that we deliver, in the services we deliver in the state of Maryland. This legislation is an expansion, a scaling up of amazing lessons learned that are being carried out in Baltimore City. It's a great example of innovation coming from Baltimore that we can all learn from and build on. And with that, I will close by just saying this is a promising strategy for Maryland to take the lead nationwide on creating a healthy state. And I would ask all of you for your favorable report. Thank you.
Thank you for your testimony. We really appreciate it. Next, we have Ms. Jamira Queen. Good afternoon, Ms. Queen. Will you be so kind and get started?
Good afternoon. My name is Jamira Queen. I'm a Baltimore City native. I'm from Baltimore City, and I'm a Healing Youth Alliance ambassador, youth mentor, and community advocate. In Baltimore City, I sit on many meetings about trauma every day, and with my team, the Healing Youth Alliance, we learn about trauma-informed care and just the effects of trauma across the city. As a team of Baltimore City youth, we have all experienced trauma. Me personally, I've experienced gun violence. I've experienced living in a community with food insecurity being an issue, and I've experienced a house fire. I know hands-on what the effects of trauma can be, and I know the importance of healing from it and moving forward. Trauma affects communities all over Baltimore City, and it has become normalized to the point that we have no emotional response to it. That needs to change. That needs to change in Baltimore City. So trauma-informed care is extremely important with healing the city of Baltimore. It has healed me having one-on-one mentors and providing mental health professionals in the city, and to have events for youth and Baltimoreans in this city is extremely important important to heal from those traumas. Trauma-informed care is so important because once we understand what is really going on and happens to us as a city, we can carefully move forward into changing it. And trauma-informed care can lead to a decrease in violence, better community leaders, and a brighter tomorrow. I know it works because trauma-informed care has worked for me, and I sit on the meetings each and every day as an 18-year-old student in Baltimore City who's experienced all of those things and more. And I know the positive effects it can have, and I know how much it can really change the community.
Thank you for your wonderful testimony today, Ms. Queen. We really appreciate you, and thank you for what you're doing in the community. It's impressive. Next, we have Mr. Cohen. Good afternoon.
Good afternoon. Thank you for having me.
Our pleasure. You can get started. Thank you.
Thank you. My name is Zeke Cohen. I represent District 1 on the Baltimore City Council, and I was the sponsor of the Elijah Cummings Healing City Act, a bill that makes Baltimore the first in the nation to legislate trauma-informed care. I want to thank you for considering making Maryland into a trauma-responsive state. We wrote the Healing City Act after a school shooting in West Baltimore. We held a hearing to identify how we could reduce violence impacting our children. A lot of the discourse among adults was about whether we should arm school police at the time. But then we heard from amazing students, Gianna, Brianna, and Damani, and they told us in no uncertain terms that we needed to stop focusing just on how to better police them, but instead focus on how to prevent not only the horrific violence that they experienced in their school, but the day-to-day traumatic incidents that had occurred. They asked us to completely transform the way our government does business. The reality is that in Baltimore and across Maryland, untreated trauma fuels violence, addiction, and many other ills that we deal with. And while Baltimore's challenges run deep, the opioid crisis, violence, mental illness are not confined by borders or boundaries. According to the Youth Risk Behavior Survey, Kent County, Cecil County all score extremely high in ACEs, particularly young people living with families that have substance abuse. And I will just say that during this pandemic, we're all suffering, and we're all suffering together. We need to dispense with the stigma and adapt a statewide strategy. The good news is that we can heal from trauma. By taking a comprehensive approach to making our state agency trauma responsive, we can reduce depression, anxiety, alcoholism, and other negative effects. I ask for a favorable report, and I thank you for your time.
Thank you for being here with us today. We have next, Mr. Frank Crows. Sir, you can get started.
Thank you. Good afternoon, everyone. My name is Frank Cross. I'm a social worker and attorney who's worked with trauma populations, mostly children and youth, but families also for the last 35 years, 22 of which have been here in Maryland. Put some slides up to help you because my job is to teach you about the foundation of trauma-informed care, which came from the most transformational and significant study I think of our age, and that was called the Adverse Childhood Experiences Study, first done in 1998, and then hundreds and hundreds of studies since then. You see the big finding down there on the right. It confirmed with scientific evidence that adversity early in life increases physical, mental, and behavior problems later in life. In other words, adversities that happen in childhood don't end because you turn 18 or 21 or 25 or 50, and they have an enormous impact on our communities. Next slide, please. So the first finding of ACEs is that they are very common. Next slide. In Maryland, the last set of data we had from 2015 tells us that 60% of Maryland's citizens have one or more ACEs. 1 to 2 ACEs in 36%, and an astounding 24%, 1 in 4, 3+ ACEs. Why does that matter? The more ACEs you have, the much more likely you are to suffer one of these physical, mental, or behavioral disorders. Next slide, please. Secondly, high ACE scores leave our citizens really vulnerable to health, mental health, and behavior problems throughout life if it's untreated. As we heard Mr. Cohn mention, we can treat it, but most trauma is unidentified and untreated. And this costs us both in suffering as well as in dollars. Next, please. What kinds of things happen? This is only a partial list because you can't even get it all on one slide. Alcohol abuse, alcoholism, depression, suicide was talked about earlier in your committee meeting today. Violence just talked about. Adolescent pregnancy, heart disease, all of these things directly tied to the number of adverse experiences you have in childhood. Next, please. So the third major finding is that without intervention, these have a strong and cumulative impact on the health and functioning of everyone in our community. And many of the things, in fact, all of the things that you've talked about today, I could even argue the lack of dental care, have an effect in terms of creating adverse experiences, health-wise, behaviorally, mentally for our citizens that unchecked end up costing all of us. Next, please. But the reason forgot I put this in here. Let's just take child abuse and neglect. One of many,
have to start, your time is up, so you have to start wrapping up, please.
Okay, 1.5 billion just for child abuse and neglect in Maryland. And then I am on the last part here. Thank you. So if we prevent ACEs, we'd significantly improve the well-being of Maryland citizens, particularly reducing suffering. And the last slide, please. And when I say transformational and significant, this is what I mean. Let's take a look at suicide, which you talked about earlier today. What that pie represents and the colors is all of the incidences of suicide in a population, in this case, in the United States. The oil slick in black, and you see 67%, is the amount it would be reduced if we eliminated ACEs. There is nothing ever been discovered, nothing in our age, nothing in the science with that much promise for improving our communities, and most of all, to reduce the suffering of our citizens. I appreciate the extra time, Madam Vice Chairman. Thank you.
Thank you. It's important. Thank you for your expertise and for sharing it with the committee. Next, we have Ms. Pam Casemeyer. Ms. Casemeyer, will you be so kind and get started? Ms. Casemeyer, are you?
Oh, sorry. I'm sorry. I couldn't get unmuted.
It's
and
okay.
My
It
video
happens.
and technology, sorry.
It's okay.
Members of the committee, Pam Casemeyer, I'm pleased to be here on behalf of the Academy of Pediatrics. And I am strongly in support of this bill. You've heard such good information already from the sponsor and the other witnesses. I'm not sure that I can add much substantively, and I know you have a long afternoon, but I did want to reinforce the fact that from the pediatric provider community, there is very little work that is being done that is so uniformly supported and encouraged as the development of policies and tools and programs that begin to address ACEs, because it not only helps the health and well-being and long-term issues for children, but that will affect your health and outcomes throughout your entire life. So with that, I will be available for questions, but mostly just wanted to reiterate what a tremendous priority this is for the Academy of Pediatrics. And thank you, Delegate Lewis, for your leadership on this.
Thank you so much. We really appreciate your testimony. Next, we have Ms. Claudia Remington. Ms. Remington, will you get started, please? And good afternoon.
Good afternoon, Chair, Madam Vice Chair and members of the committee. Thank you for the opportunity to speak in support of HB 548. I'm Claudia Remington, the Executive Director of the State Council on Child Abuse and Neglect, SCAN, a multidisciplinary advisory body that makes recommendations to the Governor and General Assembly, has spent a decade participating in technical assistance from the CDC and advocating for a statewide plan to prevent and mitigate ACEs. Currently, Maryland's minimal programs and practices to address ACEs are fragmented across public and private agencies, varying from one jurisdiction to the next. HB 548 establishes a commission to ensure coordination of state efforts, including developing a state plan. Our neighbors, Delaware, Virginia, Pennsylvania, and New Jersey, as well as New York, Tennessee, Wisconsin, Iowa, Minnesota, Washington, Colorado, California, North Carolina, Massachusetts, Vermont, and Wyoming are already developing coordinated state approaches. Pennsylvania established the Office of Advocacy and Reform that has released the Trauma-Informed PA Plan last July to guide state agencies and service providers. The Delaware Family Services Cabinet Council leads efforts to help mitigate the impact of ACEs and build resilience. State agencies are mandated to integrate trauma-informed best practices. Virginia's Children's Cabinet is charged with supporting a consistent, evidence-based, and culturally competent statewide response to childhood trauma. Building Strong Brains Tennessee is led by the Commission on Children and Youth, coordinating efforts across all three branches of government. The Office of the California Surgeon General, headed by Dr. Nadine Burke Harris, leads California's ACEs Aware Initiative and released their roadmap for resilience in December. Preventing ACEs and their intergenerational transmission is the greatest opportunity for improving the well-being of human population. The costs of childhood trauma are borne not only by individuals, but by communities and society as a whole. For these reasons, SCAN urges a favorable report on HB 548. Thank you.
Excellent timing. Thank you so much. And thank you for the work you do. Next, we have Ms. Melanie Shapiro. Ms. Shapiro, will you be so kind and get started?
Yes, thank you, Madam Chair, members of the committee. I am Melanie Shapiro, the Public Policy Director with the Maryland Network Against Domestic Violence. The Maryland Network Against Domestic Violence is the state domestic violence coalition that brings together victim service providers, allied professionals, and concerned individuals for the common purpose of reducing intimate partner and family violence and its harmful effects on our citizens. I'd like to thank Delegate Lewis for bringing forth this very important bill. I just want to talk to you for a minute about how domestic violence is one of the adverse childhood experiences. In the original Kaiser Permanente study that established what the 10 ACEs were, they've been expanded upon, and appropriately so, but a child 10 ACEs. And in the study, 12.7% of the participants endorsed that they had experienced that as an adverse childhood experience. One of the things that is most notable about that is that it often did not occur alone. It often occurred as with additional adverse childhood experiences, child abuse being one of the more prominent ones that it co-occurred with. And experiencing adverse childhood experiences increases the risk of somebody being either a perpetrator or a victim of intimate partner violence. So I'm here with a friendly amendment to ask that somebody from the State Domestic Violence Coalition be added to the commission, because we want to make sure that we are part of developing the trauma-informed response that we believe that the state of Maryland should have. So I'm asking for a favorable report with amendment on House Bill 548. Thank you.
Thank you for being here with us. Are there any questions for this panel? We have Delegate Rosenberg, followed by Delegate Kerr. Delegate Rosenberg.
Thank you, Madam Chair.
My pleasure.
I'm tempted to ask Mr. Cross which degree came first, social work or JD, but I'll pass on that. And instead ask either the sponsor or Councilman Cohn, if Baltimore City has enacted and implemented a trauma care approach, why do we need a commission to do the same at the statewide?
Thank you, Delegate. Madam Chair, if it's okay, I'll ask Councilman Cohen to take a stab at that.
Thank you, Delegate. Is that all right? Thank you, Delegate. Thank you, Madam Chair. Look, I think that we're really proud that Baltimore is the first city to legislate trauma-informed care, but really what this commission is seeking to do is to expand statewide. And again, we know that trauma, although we experience a lot of it within our city, as it relates to violence, opioid addiction, and so on, is not confined to urban spaces. It is in our rural counties, it's in suburban places. And so really what I think Ms. Remington and others have spoken to is the need for a unified statewide strategy. As we push forward in Baltimore City with our work and our agencies and our task force, we want to see that integrated into a larger statewide strategy so that whether you live in Cecil County or Montgomery County or Baltimore City, you can expect a trauma responsive, healing centered approach from the government that serves you.
Thank you.
Thank you. Next, we have Delegate Kerr.
Thank you, Madam Chairman. Mr. Cost, you did an admirable job of trying to get all that in 2 minutes, but you kind of rushed through at the end a piece of information about what the research tells us about the connection between childhood traumas and then later adult behaviors such as addiction and violence and suicide. Do you have any thoughts on that?
You're muted.
Sorry.
It's okay. It happens to all of us.
Thank you. And thanks for the question. Yeah, doing the ACE study in 2 minutes was a good challenge. So I appreciate the acknowledgement of that. The connection is why this study has endured since 1998, and also why almost 1,000 now follow-up studies have been done. So as one of the other panelists mentioned, the original ACE study had 10 adverse experiences, and I note that to you because I think all of us would appreciate that there are more than 10 types of adversities that can happen to you in childhood, but just 10 because they had to limit the study. So looking at those just 10 studies, what they found was in epidemiology, public health epidemiology, there's something called the dose-response relationship. Dose-response relationship. And what it means is for every dose of whatever you're measuring, you have an almost one-to-one concomitant response to it. And in epidemiology, a pure dose-response relationship is nearly impossible. You never see it, except in this study. And in Maryland, we were fortunate to be trained by Dr. Robert Anda in the ACE study through an initiative in the state, which I think has really spawned where we are today. And Anda talked about when he saw the original data from the ACE study showing this dose-response relationship, which simply means this: if I have no ACEs, zero whatsoever, my likelihood of experiencing serious illness, mental illness, behavioral problems in the United States, in the group that they studied, is only about 5%. But when I get to 3 ACEs, that triples. When I get to 5 ACEs, that quadruples. Really incredible findings, step by step by step. And Anda says, when I saw that data, I wept. And I wept for 2 reasons. One, because he was so committed to finding out why. And I know many of you have to have that question too. Why do we have this level of suffering in our community? Why, despite all of the efforts that you've made over the years as a legislative body to fund and to sponsor and to listen and to vote, that we still have this prevalence of people who suffer in all of these areas? And why, since we're so well educated in the United States, is heart disease before COVID, right? Heart disease, a #1 killer. We know what prevents heart disease. And if it was knowledge that was all that was necessary to prevent, there's got to be more. And Anda said, I wept because I never saw the dose-response relationship as pure as it was in ACEs. And that told me that it's those adversities, it's those traumas. And we don't measure them, we don't identify them, and consequently, we don't treat them. So the biggest issue facing us as a society, I believe, is unidentified, untreated trauma. And we're so far behind because we don't even have systems to identify it. If you thought you had a child or knew a child, for example, that might have been traumatized, or you know a young adult that might have been traumatized as a child, how would you find out? How would you know? Where would you go? We don't even have a system for it. So this establishment of a commission gets us started to look at how do we attack that idea? How do we build a system that really has trauma at its focus? Because trauma is the basis of just about everything we're facing. And one last thing, and I appreciate so much time. One last thing, please go and look real quickly. Just Google opioid addiction and ACEs. Opioid addiction and ACEs, because I know opioid addiction is something we're all concerned about. I live in Harford County. We're enormously concerned about it. And you'll be amazed at the number of studies that directly link ACEs and opioid addiction in adults. This is finally the way, if we can unite around it and support the investigation of it, that will develop a comprehensive, systematic approach. Very appreciative of all the time. Thank you.
Thank you. That detail was helpful. And thank you, Madam Chairman.
My pleasure. Delegate Bagnall.
Thank you, Madam Chair. And again, thank you to the bill sponsor for bringing this. So I know that that we are all, our brains are very much in COVID. So whoever can speak to this, why is effective prevention and response to trauma how is it going to be part of the Maryland COVID-19 recovery effort? Why is that important that we do this now?
Thank you. I think I'll try to answer your question, Delegate Bagnall. So right now, the COVID response is very focused on the vaccination rollout. Why are vaccinations important? In an infectious disease model, vaccines prevent infection or severe illness. Vaccines are a prevention tool in the public health arsenal. I think that in the same way that a vaccine prevents infectious disease, attention to ACEs can prevent the other kinds of harms, injuries, difficulties, and burdens that we suffer. An approach to ACEs has the potential to act like an inoculation. And I think to the extent that we can set up, build out, and implement an affirmative approach to dealing with ACEs, the better off we'll be. It'll amplify our efforts to address COVID. Remember that the most vulnerable people to COVID infection, morbidity, and death are those who have experienced all those ACEs. People who are suffering homelessness, people who don't have access to basic health care, preventive health care, folks who are already having difficulties dealing with other challenges. The folks with the most ACEs are at most at risk of COVID. So I think this is a way for us to address both. I hope I answered your question.
Thank you. Thank you, Madam Chair.
Thank you. Any other question for this panel and for this bill? Seeing none, this concludes the bill hearing on House Bill 548. Members, it is 3:13. We're going to take a break until 3:45. Okay, when we come back at 3:45, we're going to be joined by the Appropriations Committee to do House Bill 552. And then the final bill of the day, our wonderful colleague, Delegate Kelly, House Bill 598.
Okay.
Till 3:45. Final bill of the day, our wonderful.
You're on break now? Oh, I came in.
Should we log off or hang out?
You can log back in if you want, or you can just take the video off, but we'll be back at 3:45.
You don't have to sign out.
Yeah. Hold on a minute. I'm looking to mute myself. Okay, good afternoon. People a few seconds. It is 3:45. I think we all could use that little break, right? So I appreciate you being flexible. We have 2 bills left and then we're done. So let's make sure we have everyone here. Melissa, do we have Delegate Holmberger?
No, he's not with us yet. I just resent him the link again.
Okay. So we have next House Bill 552 and Delegate Hornberger, Maryland Medical Assistance Program, Emergency Service Transporters Reimbursement. Give the delegate a minute to get in. We'll get started with one of his witnesses. Is Mr. Theodore Deldridge here? Doctor?
Yes, ma'am.
Will you be so kind and give us your testimony? You have 2 minutes. Welcome to the Health and Government Operations Committee.
Certainly. Thank you for the opportunity. So,
our pleasure.
Hi, I'm Dr. Ted Delbridge. I'm the Executive Director for the Maryland Institute for Emergency Medical Services Systems, or MEMS. And we're responsible, the state agency responsible for overseeing and coordinating the statewide EMS system. We do that through licensure and certification of EMS clinicians or the paramedics and emergency medical technicians in the field, by designating EMS operational programs for those agencies authorized to provide emergency medical services, promulgation of the clinical protocols used by clinicians in the field, and designation of trauma and other specialty care centers. Currently, Medicaid compensates EMS providers a flat rate of $100 for transporting a Medicaid beneficiary to a hospital. It doesn't matter how far it was or how long it took. It doesn't matter how much care was required and the expense of consumed supplies and medications. And it doesn't matter what the necessary personnel qualifications were to provide the needed care. Medicaid compensation requires that EMS take the person to a hospital and encourages more expensive care. And it doesn't compensate EMS when definitive evaluation or care is provided at the scene without transport. The current rate of $100 in and of itself is outdated. It hasn't been updated since 1999, a generation ago. It offsets a mere fraction, between 15 and 20% of the actual cost to provide EMS care to a Medicaid beneficiary. And similarly, it is approximately only 15% on average of what commercial insurers compensate for advanced life support services, and only 25% of what Medicare provides. Even if $100 was an appropriate approach in an amount in 1999, it would be logical to adjust it to more than $150 merely on the basis of inflation, something the bill puts us on a trajectory to do. House Bill 552 provides a modest approach to improving inadequate compensation to those who unselfishly provide care to Medicaid beneficiaries at any time of the day or night, often volunteer agencies. It acknowledges the value of the care that is provided regardless of whether or not there's transportation to a hospital emergency department. And thus, MEMS supports House Bill 552 and hopes for a favorable report. Thanks.
Our pleasure. Before we go to Delegate Holmberger, I have actually Delegates Valentino Smith, Delegate Mangione, and Delegate Henson from the Appropriations Committee. Welcome to our committee. It's wonderful to have you. And let me know if you have any questions when we're done. You could use the little hand where the participant icon is, and I'll call on you. Delegate Holmberger, will you be so kind and get us started?
Yes, thank you, Madam Vice Chair. And some of my testimony today on HB 552 may echo some of the sentiments that Dr. Delbridge had just presented. Do I have the ability to share screen in this committee?
Yes, you do.
Okay, thank you. It says host disabled participant screen sharing. I'll just go ahead and jump into the testimony here. Very quickly, what I wanted to present is there is an article that was recently published by NBC News that said, what happens when you dial 911 and no one shows up? Now, in rural America, we are facing a crisis, and that is ability to access quickly EMS care. And the reason that that is occurring is because the vast majority of these services are provided by either the county or by volunteer departments. They are hemorrhaging money largely because of this EMS transport. And the reason they're doing that is because when they go to pick up someone, they can't discriminate against who they're picking up. They have to provide the service. And in many instances, that person that they're picking up either A, refuses to be transported to the hospital, or B, is transported to the hospital and does not have insurance.
Excuse me, Delegate, you can share screen now.
Oh, okay, great, thank you. And
My
let's see
pleasure.
here. Mhm.
When the timer is on, we're not able to do both. So Ms. Bender is going to keep your time, okay?
Great, great. And in
Take a
our
look at
committee,
her.
we put one of the icons as the timer, just
Yeah.
food for thought there. But so anyway, back to the testimony. So what ends up happening in that situation where the person that's being transported doesn't have insurance is that they have to be taken to the hospital, and then the fire company, EMS, or the county has to seek out money through Medicaid. And that currently that rate is only $100. Now, currently, when you transport someone in a privately held ambulance, that company is being reimbursed anywhere from $1,000 to $5,000. So you can imagine that $100 is a major disincentive for a private carrier to pick up that person or transport them. And ultimately, what is occurring is that when the call is made from the dispatcher calls these private insurance group or these private carriers, and they are turning down calls, or they're saying we can't get to that call until later in the day. That person languishes, and then the dispatcher then calls upon the volunteer company or the county. They can't refuse or say that they have someone else on the list, so they end up picking up all of these calls that don't have insurance. So what this bill seeks to do is to move that rate that has not been changed since 1999 over years incrementally to $300. Keep in mind that both PA and West Virginia are currently at $350 minimum. And this bill also seeks to future-proof that reimbursement rate. In the legislature, we try to shy away from mandating a fee codified in the legislature. So that's why there's language in there that says if the Medicaid Reimbursement Board decides in the future to raise it above $350, they can do that without having to come back to the legislature. In closing, the last point I'd like to bring up is to really hone in on that treat but not transport. That's the TNT call, as referred to as in the industry. And these are generally an overdose call. So if you will, someone overdoses, a colleague or themselves calls 911, ambulance arrives, they administer the Narcan, and the patient refuses to be transported to the hospital. Currently, there is no vehicle whatsoever for that EMS company to be reimbursed for that service. So this, in closing, that this provides a way for that to be reimbursed and is going to go a small way, but a very important way to keep our private small carriers and the local volunteer groups from going under. And with that, Madam Vice Chair, I'd love to take any questions. Thank you.
Thank you. I have next Mr. Alex Butler.
Good afternoon, Chair, Vice Chair, members of the committee. Alex Butler with the Maryland Association of Counties, here in support of House Bill 552. Thank you to the sponsor who stepped in to address this important issue for counties. The approach in the bill is very sensible and has Medico's full support. Other states' reimbursements are more in tune with the EMS services they actually provided, and this bill would provide an update, a needed update to Maryland's. Many EMS programs are self-funded through fundraising or supplemented by county expenditures at a time when costs are only on the rise. So this bill gives EMS providers a path forward for reasonable reimbursements for the critically important services they provide. Thank you to the committee for its consideration, and we urge a favorable report.
Great timing there. Are there any questions for this panel? We have Delegate Valentino Smith. Welcome.
Thank you, Madam Chair. It's a privilege to be with you today, especially after you all have had a snack and are not hangry. If you may, Madam Chair, the Appropriations Committee, I guess you bring us over to talk a little bit about fiscal impact. I've looked at the fiscal note and I just wanted to take a minute with the committee and Dr. Delbridge and the sponsor to see if I could confirm a couple things with them. So last year in 2019, in the budget, we asked for joint committee reports, and we do that to gather as much information as we can about a subject that we think has the potential to save the state money and or cost the state money. So for purposes of this in 2019, I just want to let you know there was a JCR report, just briefly, talking about the various programs that they're starting to implement for not taking somebody straight to a hospital. So Dr. Delbridge, these programs have the potential to have a significant impact on health system costs, emergency department overcrowding and wait times, EMS unit turnaround times, and patient satisfaction. Currently, EMS is not reimbursed by health payers for any of these three models. Because EMS services have historically been viewed as a transportation benefit, EMS is not reimbursed by public payers, Medicaid or Medicare, or private payers unless a transport is actually to a facility. So what it ends up concluding is that the report validated the need for long-term sustainable funding for this type of service. So Dr. Delbridge, when you came before our committee last year, in addition to the JCR report, or you're new, I don't think you've been before us yet, have you? Okay.
So what's the, we need to
question is, isn't it true that there was a JCR report, the budget committees have looked at this, and it concluded that this type of service, although it has some fiscal note on Medicaid, actually has the potential to have greater cost savings?
That's my perspective, that the ability to not take people to the hospital, to not incentivize EMS services to take people to the hospital when they don't necessarily need to go, when it's possible to provide the care they need right at the scene, would be much less expensive for the system than it is currently designed. And the proposals to finance, to pay for care at the scene has broad implications and is under review by all the payers of healthcare. In fact, there are a few Maryland EMS jurisdictions right now that have embarked on a program with Medicare. It's called ET3, Evaluation, Treatment, Triage, and Transport, that specifically gets at these issues. The options to do some telemedicine work at the scene, to take people to less intense care than the emergency department, such as urgent care or places like that. And so we would be out in front of the issue if Medicaid was to reimburse EMS services for the care they provide at the scene without necessarily transporting patients to the hospital. And as the delegate said, oftentimes these cases are overdose cases, but oftentimes there's care that is even more expensive to provide at the scene, like reviving a diabetic who's hypoglycemic and consumes a fair amount of expensive medication, but then awakens and knows what is wrong with him or herself and doesn't need to go to the emergency department. It's only appropriate that we reimburse EMS for that. And it's cheaper than taking the patient to the emergency department.
And Madam Chair, if I may, just one more question.
Sure, we only allow one, but since you're visiting us, we're going to be kind. Go ahead.
Thank you. And because we in appropriations tend to have stacks and stacks of information that doesn't appear in your fiscal note, I thought it might be helpful.
No, we appreciate it. Go ahead.
Let you know, in addition to the 2019 JCR report that Dr. Delbridge and the sponsor and I just talked about, in last year's, in the 2020 budget analysis, which you can all read tonight at your leisure, it's easy to find, but I just want to highlight for Dr. Delbridge, then after the JCR report, in our budget analysis of last year, there was a requirement that the Maryland Healthcare Cost Commission do a report on what savings this would be also to private payers. And in that report, particularly at Exhibit 7, Dr. Delbridge, isn't it true that a year later, we continued to hear in the budget analysis that this type of model would ultimately save not only ED waiting times, but costs to the public and private payer?
That is the assessment, yes.
Thank you, Madam Chair. I just thought if you're bringing appropriations over, you ought to let us show you what we got. Thank you.
Well, you certainly showed us what you have. Thank you. We appreciate you. Any other questions for this panel? Okay. Thank you very much. So seeing none, that actually concludes the bill hearing on House Bill 552. So we want to thank our members from Appropriation. It's great to see you and to visit with you. Enjoy your afternoon. This concludes the bill hearing on House Bill 552. We have the final bill of the day, House Bill 598, and that is Delegate Kelly, Maryland Medical Assistance Program, Applied Behavior Analysis Services Reimbursement. Good afternoon, Delegate Kelly, and thank you for being patient.
Absolutely. Thank you, Madam Chairman and members of the committee. Big stretch, final stretch of the day. I always bring you easy bills that you love, right? So this is the bill that's in my heart this year. So if you can just pay attention to me, I might take the whole 4 minutes and 50 seconds, and then I have a panel, but there's no opposition panel. So hopefully you can just be patient and then we will be done. This bill will make you feel good about yourselves. It is going to increase access to autism treatment by eliminating an inequality between families who are in Medicaid and those with private insurance. Specifically, it's going to remove a burdensome and unnecessary requirement that the parent be present on site for all treatment. That's a requirement that's in the Medicaid system, but not in private insurance or the state health plan. If we want to take our time machine back a long time, I know the chairman remembers this, Delegate Kipke, Delegate Cullison, there are Delegate Krebs, a couple members who were on the committee back in 2012, my first term in office, when we passed legislation that eventually required insurance coverage for ABA treatment for children with autism. The advocates who helped with that, Rebecca Rienzi and Judith Orsetti, are here today. They're going to provide this update for you. When we passed that bill, eventually we required private insurance coverage. The state health plan followed suit and adopted the coverage, and Medicaid began the process of including ABA, applied behavioral analysis, which is a very common autism treatment, in their coverage. That was 2012. In 2014, CMS bulletin explicitly stated that medically necessary ABA treatment needs to be covered by Medicaid. Please note that it did not state in that bulletin that there should be a requirement that a parent need to be present. It is required for coverage if the treatment is medically necessary. That bill that we passed in 2012, people still come up to me in grocery stores and give me hugs, not now because of COVID, but in the old days, give me hugs with tears in their eyes and say, that bill changed my life. Thank you so much. It changed my family's life. And I personally really understand where they were coming from. Those of you who weren't here don't remember this. Those of you who were do, but in December of 2010, which is right after I was elected, before the beginning of my term in office, my son Leo got an autism spectrum disorder diagnosis. He had been kicked out of daycare for bad behavior, and I ended up at Kennedy Krieger. It was 3 days before Christmas, and I can still remember that doctor, the way she looked at me, and she said to me, here's the deal. Your son is 3 years old. His brain is very flexible until he's about 6 years old. And his outcomes, his eventual ability to become the best he can in life is really dependent on how much treatment and if he gets the right treatment these next 3 years. I felt like there was a ticking clock just going tick, tick, tick. And I had to just drop everything to make sure that my son had the treatment he needed so that he could fulfill his potential in life. My daughter, Maeve, who's 3 years older than him, refers to those as the lost years in her childhood because she didn't see me much those years. I really committed everything I could to making sure that Leo had the treatment he needed. And that was anywhere from 3 to 5 days a week. Mind you, he'd been kicked out of daycare, right? So he wasn't in another school. But we put him in all of this treatment. It could be 20 hours a week or 30 hours a week, depending on the different treatment plan. I, of course, had a job. I had 2 jobs, and I needed that money to support my family. So I ended up hiring 2 different babysitters to help get Leo to and from the different treatment he needed. I would go 1 day a week to take him. I would telework from the Panera near the center where he was getting the treatment. And then I would pick him up and drop him off and meet with the therapists and get the parent training so that I could reinforce the things he was learning at home. I went to parent meetings every couple of weeks with other parents to learn from them and their kids and the therapists. It was very active, but I was not required to be present at every hour of service. That would have been unreasonable and unhelpful for my child. That was the hardest time in my life. But Leo, God love him, he's going to be 14 soon. He has straight A's in a gifted and talented learning disabled program now. He is able to maximize his potential because of that early treatment he got. And that story would not be possible right now for a child whose family is enrolled in Medicaid. So I really hope we can lift that restriction. Expecting parents to sit for 30 hours a week in a waiting room while their kid gets treatment is not realistic. It forces a heartbreaking choice between doing the work work you need to support your family and your child's future. I will reiterate that is not required by the CMS rules. CMS rules that if it's medically necessary, we have to provide the treatment. And one last point that is really critical, I touched on the importance of parent training and parent involvement. This bill will not eliminate parent training or involvement. It just acknowledges that there's a wide space between having parent involvement and requiring that the parent always be present for every hour of treatment. With that, I will pass it off to my panel. I think Rebecca was going to go first.
Yes, I have Rebecca Rienzi. And thank you, Delegate, for your leadership on these very important issues, you know.
Thank you for your longtime support.
Thank you. Ms. Rebecca Rienzi.
Thank you. I'm Rebecca.
Saying your last name.
I am the Executive Director of Pathfinders for Autism. We are a Maryland organization dedicated to helping individuals with autism and their families through resources, training, and recreation. Last year, we served over 19,000 Maryland residents, and I am, of course, here today in support of House Bill 598. ABA is a common behavioral therapy that can help people with autism to reach their full potential. The Medicaid requirement that parents be present during ABA services is arbitrary, burdensome, and creates an inequity in access to medical care between those with private insurance sold in Maryland and the recipients of Medicaid. And it puts the parents in the position of having to choose between work and other family obligations and getting the medically necessary treatment for their child. 152 Maryland children are diagnosed with autism. And there are over 12,000 children in Maryland public schools with an autism diagnosis. And 1/3 of children in Maryland are covered by Medicaid. Simple math, that is a lot of children that are not getting equitable access to treatment, which is already noted was mandated by CMS in 2014. The requirement that the parent be present for services is not clinically necessary or appropriate. It is not required under the 2014 mandate, as the delegate noted, that we passed to cover ABA under private policies, and it is not included in the Medicaid state plan amendment that was approved by CMS in 2017. Under this rule, Maryland Medicaid is creating systemic barriers that inhibit access to medical care for thousands of the most vulnerable children in our state. Beyond the issue of equity, the requirement is fiscally irresponsible, forcing a family to choose between employment and treatment, employment that could reduce the family's need for public assistance programs, and the treatment that could, over time, reduce the child's need for special education services and adult service programs covered by the state. I respectfully ask that you vote in favor of House Bill 598.
Excellent timing. Thank you.
I practiced.
You did well. Erin Camp.
Good afternoon, committee members. My name is Dr. Erin Camp. I'm the chair of the Legislative Committee for the Maryland Association for Behavior Analysis, and I work as the regional director of the Baltimore area for Little Leaves Behavioral Services, which has provided ABA therapy to children with autism in Maryland for nearly a decade. Like Delegate Kelly mentioned, we were thrilled to have the Maryland legislature pass laws allowing children with autism access to ABA therapy. And as a result, many children are now successfully getting the treatment they need. Unfortunately, the majority of the children that are benefiting from this treatment are those that have private commercial insurance. Only a small percentage of the nearly 700 licensed behavior analysts in Maryland are Medicaid providers. The structural barriers, like the parent presence requirement, have prevented many providers from being able to accept children with Medicaid, including the organization that I work for. Last year, we spoke extensively with Optum to enroll as a Medicaid provider. And when we learned of the requirement for parental supervision for therapy, we knew that it would be unrealistic or almost impossible for parents to enroll their child in a research-based intensive program like ours, where kids are coming for a full recommended dose of 30 to 40 hours of therapy per week. And even if we could make that possible, we wouldn't be able to accommodate all those extra adults in our building all day. It would restrict our space. We wouldn't be able to provide space for other children. And certainly during COVID, it would introduce all kinds of health risks. And we're just one example of the many providers in Maryland who are not able to provide therapy to a more equitable distribution of clients. This is a story that hundreds of other providers and families have shared. The behavioral analysts in Maryland really are dedicated providing services to create differences in our community for all children that are available, regardless of their source of funding. So elimination of the parent presence requirement would greatly increase our ability to serve children and help eliminate disparities that are created by this requirement. Thank you.
You did excellent. Thank you. Next, we have Ms. Judith Ursidi.
Thank you, Madam Chair and members of the committee. I'm Judith Ursetti, and I am Vice President of Community Affairs for the Council of Autism Service Providers. We're a nonprofit group of providers trying to make sure that evidence-based services are provided in schools and the healthcare setting in the community all around Maryland and across the country. I've been involved with autism insurance reform efforts in Maryland for more than a decade. And as Delegate Kelly told you, we passed legislation several years ago requiring private health insurance coverage for medically necessary care. Subsequently, in 2014, CMS came out and under the provision of EPSDT recognized that autism spectrum disorder is a childhood health condition that EPSDT applies to. And subsequently, the regulations were developed that creates this amazing service for Medicaid enrolled children with autism so that they too can have access to medically necessary care for autism. It is important that a doctor prescribe this treatment, that it's medically necessary, that there's a treatment plan, that parent training is involved. But the requirement that parents be present at all times is not only a major inconvenience, it really violates EPSDT. If you think about it, EPSDT is for the child, for any child, whether they have parents, whether they have caregivers, or others who can be present at all times or not. It's urgent and fiscally prudent that children have access to evidence-based care. So not only is this an issue of convenience and economics, it's also an issue of violating EPSDT. So I ask that this simple correction be made, and I support House Bill 598 in doing so. Just eliminate that requirement that parents be present at all times. Thank you so much for your consideration.
Thank you for being with us today. I want to skip one witness quickly just to see if Dr. Tanzuna, are you here? Let you go first because I believe you have a patient.
I believe she already had to leave. Actually.
Okay. All right. So then Ms. Jennifer Langley.
Hi.
Hi, good afternoon. How are you?
I'm good. I'm good. I was going to read, but you guys have made me nervous now, so I'm going to talk.
You know what, Jennifer? You have 2 minutes, but I tell you what, just speak from your heart in those 2 minutes, okay? Just speak from your heart. We're listening to you.
My heart will tell it all then. So I am a mom with 3 sons with autism. I have 2 11-year-old twins that have autism and their younger brother who's 10. So basically, might as well call them triplets. So the boys were all diagnosed before the age of 2, and we were lucky enough to be able to experience some ABA services in early intervention and research practices that allowed us to get a good stance of where ABA would take us and how well it worked for my children. I support the bill 100% to make it into a clinical setting and to be able to have families have that interaction for their kids, because in my unique circumstance, I have 3 sons with autism. So that will require 4 providers at a time to come in my house, which is small. They all needed separate areas. The need was there for them for years. They're older now, and it took me probably 4 years in multiple agencies to be denied. And we just could not get these services. We couldn't get the services. And if there was some clinical based places that we could go, it probably would have been a lot easier. We were turned away because, it was too many. You can choose one kid, not the other. There was lots of problems with the fee schedule for the providers, and lots of hoops that they had to go through to be able to come into home. So we weren't really able or successful to access it in 4 years. I support the bill 100%. to offer it for families like mine that need it. Like, we truly, truly need this. And I hope that you guys take the time to read my written testimony, because it was a lot more to the point. But I just wanted you to kind of know it's genuine and to the heart when you're seeing friends of yours that you go to support group meetings with, their children are getting services because they have private insurance. And in a case like mine, I'm a single mom with 3 disabled children. I was not able to work. I had to take them to therapy after therapy after therapy after therapy. And I dedicated that time because they needed it. And my children have been successful. They all go to Kennedy Krieger, and they've all had success at getting to certain milestones. But without these vital services, they wouldn't have made it. And they still need it now, and it's not available to them. But I'm more here to speak for younger kids and kids that are coming up, that this should be a covered item. It's definitely, the insurance should open it up to the clinics, and they should also not make us feel like we're less than because we're on Medicaid.
Jennifer, you spoke beautifully from your heart.
Thank you.
Thank you for being here and for sharing your personal experience. Do listen, and the committee does read the testimony that is given to us, so we'll read it, okay, as well. And a lot of us have already read it. So thank you so much. We really appreciate your time. Are there any questions for this panel? We have Delegate Carr first, followed by Delegate Collison. Delegate Carr, good afternoon.
Thank you, Madam Chair. Can you hear me okay?
Yes, we can. Thank you.
Good. Yeah, thank you, Delegate Kelly. Thank you all for bringing this bill. As a parent of a child who has a diagnosis on the spectrum, I greatly appreciate it. So my question has to do with this idea of requiring parents to be present during ABA services therapy. Can you talk a little bit about how that works in other states and how that would work also for private insurers?
So Delegate Kelly, who's the best person to answer that question?
I think Judith probably has a great answer.
Thank you,
Yes.
Delegate.
So I'm so glad you asked that question, Delegate Carr. In other states, I actually work on this issue nationwide. Parents are definitely required or strongly encouraged to be part of developing the treatment plan, observing at times, being part of the team of the ABA delivery. However, I'm not aware of any other state that requires parents to be present at all times. I think in Maryland, and I was actually involved in the development of these regulations, and we pushed back at the time because we thought they were taking it a step too far, and that has proven to be accurate. So no other states are doing this. Also, private health insurers, not just in Maryland, but in the other 49 states, which now require the coverage, they do not require parents to be present at all times.
Thank you.
Thank you. We have Delegate Collison, followed by Delegate Lewis.
Thank you, Madam Chair, and thank you, Delegate Kelly. And I'm still reeling over the fact that Leo is 14. How did that happen? So I remember when. So I'm going to cheat a little bit, Madam Chair. So I want to go back to Mr. Seedy and ask, so this bill in no way limits parent engagement in terms of parent engagement. So if you could just speak to what that looks like. You started a little bit in response to Delegate Carr, but what does it mean to be engaged and what's valuable parent engagement? But my cheating part is, I was looking at the Maryland Health Department letter, who are saying that this could put a greater burden on the medically necessary services, because they would be not served in the schools, or they would shift from the schools to the Medicaid services. And could you speak to the difference between what's done in schools versus the medically necessary services?
Absolutely. And I will say too, I speak not only as an advocate, and I want to be clear, I worked for Autism Speaks for 10 years and have recently gone to work for Council of Autism Service Providers. So, and I'm also the mom of a 17-year-old who you might hear in the background. He has autism and a severe intellectual disability and could actually make an entrance at any time. So I live this situation with regard to accessing services. So I think, to be clear, again, when you talk about how a parent is involved in the treatment plan, whether it's through private health insurance or whether it's through Medicaid, the doctor prescribes medically necessary care. So they're going to decide what the dosage is. Autism is a spectrum. Some kids don't need ABA at all. Some kids, like my son, needed 30 to 40 hours when he was very young. And so that's a lot of intensive, important treatment that helped him learn how to communicate with an iPad. It taught him how to point, taught him how to say basic things like yes or no, which is so liberating for a human being. So very important there. The doctor prescribes the treatment at the appropriate time. Treatment plans are evaluated regularly, both in that private insurance space and in Medicaid. And then parents come in because you want to make sure that the skills that a child is learning in those sessions are generalized to home, so that if they go to the refrigerator and they need something to drink, they can communicate it. Parents know how to implement those programs. It also works both ways. Parents communicate to the team what is going on. So for me as a mom, honestly, I can communicate that my son has a violent reaction when my daughter speaks because he doesn't like the sound of her voice. What am I supposed to do about that? My daughter talks, and my son is trying to attack her. So that back and forth helps evolve the treatment plan. And it's very important. And it is included. It's included in the COMAR regs. It's clear the treatment involvement for parents is there. The only thing that's being removed is the requirement that they be present at all times in the therapy session. And forgive me for being so long-winded. I will share quickly with regard to what in the world is the difference between this medically necessary health insurance funded care and what happens at school, and how is that burden being shifted back and forth? Well, they're two different things. School, if you're my age, which I think you might be around the same age, when I was back in the 70s in elementary school, kids with disabilities didn't have the right to be there alongside their peers. And then this amazing piece of federal legislation was passed called IDEA, and it allowed students with disabilities to access the curriculum, but they needed the right accommodations to do it. That's what educational ABA is all about, helping a student access the curriculum. So those specific goals that go to that. When you think about care that a doctor's prescribing that's medically necessary, whether it's funded by private health insurance or by Medicaid, that is meant to ameliorate those really challenging symptoms of autism. So you have maladaptive behaviors, severe social communication issues, things that are much more clinical in nature, ameliorating those challenges, building those strengths. And so then that can help a student actually get to where they can get to school and access the curriculum. And in the long run, everyone wins.
Thank you. Thank you very much.
Thank you so much for your answer. Next, we have Delegate Lewis, followed by Delegate Belcastro. Delegate Lewis.
Thank you, Madam Chair. Thank
My
you,
pleasure.
Delegate Kelly, for bringing this bill. I learned a lot in listening to the testimony. I don't have a lot of experience understanding autism. I know what it is clinically, but I'm curious to know a little bit more about what applied behavioral analysis services look like. What does a treatment plan actually look like? That would be really helpful, whoever you think is best to answer.
Rebecca, do you want to grab that, or Erin? Maybe Erin is probably the best.
Erin, yeah.
I'd be happy to. This is the kind of treatment that we do here at my center. So we're focused really on early intervention services. So those very smallest children who are just getting their diagnosis at 2 and 3 years old, who are trying to get ready for school. Ours are center-based services, so they're here with us all day. We assess their needs and their symptoms of autism basically across every category of their day. Their communication skills, their social skills, their repetitive behavior, any challenging behavior, their adaptive skills like taking care of themselves. And what we'll do is create a treatment plan that's going to address where they currently are and where they should be according to their developmental stage. And what we know with children with autism is that they're not going to just pick up these things like they would at daycare by watching somebody else. They need high intensity, explicit therapy to be able to learn these very small skills over time so that they can be successful in the way that their peers might. So what we're doing is taking our whole day and trying to build those very small focus steps so that we can build the skills across the day that a child would need to be successful later on, but really being purposeful and structured in the way that we're teaching it. So if we want to work on asking for things, we will make a specific, I want you to be able to ask for these 3 things, and I'm going to practice it 50 times today. And this is how I'm going to do it, to be very structured in how we teach those skills. And then we have goals for basically all the parts of the day on what we need to work at in each area.
So it's really kind of about breaking down some sort of standard behaviors or skills and just one by one.
That's exactly right. For a child with differences in development, maybe learning to speak doesn't just come from exposure to other speaking people, but they need targeted intervention to very slowly develop the ability to speak, or to use some kind of alternative communication, like using an iPad or using sign language or something else to get their needs met if they're not going to be vocal speakers.
And if the kids get that, I mean, barring other cognitive or other issues, they can really reach their potential.
Absolutely.
And end up like Delegate Kelly's son. So that's amazing.
Research that suggests that doing this big intervention early on in life is really the thing that's going to have the greatest impact in lifelong success of getting kids able to be as independent and successful as possible by doing this very early intervention, which is 30 and 40 hours a week. It's a full-time job for them and for us. And we wouldn't ever want a kid to not be able to get that therapy because their mom can't quit her job to come and can't afford to send a nanny with them, or can't do those things for them to be able to get what they need.
Thank you so much. Really appreciate it. We have Delegate Belcastro next, followed by Delegate Krebs.
Thank you, Madam Chair, and thank you, Delegate Kelly, for bringing this bill. And just as a special education teacher, I want to thank you for sharing your personal story about Leo. It really warms my heart to hear about his success. My question is, it was brought up in the testimony that there can be a large amount of hours that are needed for therapy, 30 to 40 hours a week. And my question is, are these services provided after school hours, during school hours, or is it sometimes provided in lieu of attending school if the interventions are happening not necessarily in those preschool years?
I don't know if Erin or Rebecca wants to answer that.
I'm happy to take a stab at it. In the early intervention years, we do focus in more of that center-based structured school readiness. As kids get older, and hopefully as they've had more exposure to therapy, we start to move those therapy treatments into home and community-based settings. And there's some amount of home therapy that happens even in the early intervention yet. So it's not exclusively center-based for early intervention children either. But as kids get older and start entering school, behavior analysts can go to school with them and help develop support plans. As children are having after school activities or participating in community events, the behavior analytic team can go with them and continue to help support their growth in a greater community aspect as they get older. And we do find sometimes that intervention time does decrease, especially if they've had this early access to intervention in those early years. If they're still getting behavior analytic treatment in their later educational years, the requirement for how much therapy they need could be shifted some responsibility to the school to be able to give them that educational support, and then lower doses of ABA therapy to give the supplementary support in the community or home that they would need.
Thank you very much.
So can I just have one follow-up?
Sure.
Thanks, I appreciate it. So just so I understand, children are still attending school. They're not leaving school or in lieu of school getting these therapies?
It will depend on each child and depend on whether they're attending a general education classroom or a special education classroom or a private special education school or homeschooling. So each family is going to have to make specific educational decisions for their child depending on how their symptoms of autism are being demonstrated. And so there's room for the behavior analyst to be acting in a lot of different ways depending on where that child is in their growth and in their educational access.
Thank you very much.
I don't know if I could answer a little bit of that.
No,
too.
we're only allowed one person at a time. So Delegate Krebs.
Thank you, Madam Chair. Thank you all. It sounds like the original policy, and I'm trying to remember back, was implemented to enhance the quality of services and to improve the outcomes. And they thought that the involvement of parents and caregivers in treatment was essential to that. So given that, and you say the private insurance doesn't require it, is there any kind of a like middle ground to make sure it says present or available? How do we ensure that all parents stay available and involved in this? And how do you look at those outcomes with regard to Medicaid versus the private insurance if they're not requiring it?
Delegate Kelly, who's the best person to answer these two questions?
So the first question was, what does parental involvement look like if we don't have this mandate? And the second was, how do we measure outcomes?
Compared to the private insurance is not doing it, how do you say that, hey, it's working without it? It's working fine.
Well, I think I can answer that. I mean, honestly, we know that it's working in private insurance. We know that people are getting access to the care that they need. In terms of what does parental involvement look like, I think Judith answered that already in her earlier answer, but this bill does not prevent Medicaid from doing any number of things in terms of creating parental involvement programs. But what it does do is say they can't require that every hour of time that the child is in therapy, the parent is sitting in a waiting room, preventing themselves from being able to work. And it then equalizes access to care for children in Medicaid and in the private insurance market.
Okay, thank you.
Any other questions for this panel? Seeing none, thank you so much, every one of you, for coming, sharing your stories. The committee really appreciates you and your time and your experiences. This concludes the bill hearing on House Bill 598. And members, it also concludes the work of the day. So I hope you have an amazing